So I'm going to demonstrate to you the procedure of phlebectomy. We have a young lady here. She's 32 years old.
All right, well, I guess we're going to get started again. I think the crowd has decreased a little bit. Maybe some people are going to come back in. But in our last session this afternoon, we're going to basically talk about techniques, complications, how to avoid complications when doing an ambulatory phlebectomy. I'm going to start out with just some of the simple things that I think make the procedure very easy to do and very easy to learn. And then Dr. Romy Chopra is going to spend some time in addition to Dr. Sanchez. So if we could put my slides up, that would be great. I don't know about this lessons from an expert, but I have sort of mastered the technique. So if you look at phlebectomy traditionally, this is what people would show you a slide of when they're telling you why you don't want a phlebectomy, which is all these big, nasty scars that the patient has in her leg. But in fact, you're going to learn how to do it to avoid those. What I would tell you is that here's a patient who's had a laser vein ablation with phlebectomies, and that's her leg 8 weeks later. And certainly from a cosmetic point of view, in addition to a symptomatic point of view, you just get a very rapid result very quickly with phlebectomy. And this is opposed to sclerotherapy, where these are patients that I saw for second opinions who had vein ablations and sclerotherapy. And these people are 3 or 4 months out, and you can see all the hyperpigmentation that they have throughout their legs. This will generally resolve over time, but it can take 1 to 2 years for hyperpigmentation of that intensity to go away. So I think it's worth learning how to do a phlebectomy. I think whether you're a cardiologist, a radiologist, a vascular surgeon, you can learn and master techniques to do a nice phlebectomy. So a few of the things you have to do is you have to mark the patient's veins, so when they're laying in a supine position, you know where they are. And so we do this before the patient's procedure with them in the upright position. Sometime if it's your first case in the morning and it's cold outside, they may have a little bit of vasospasm, and I will frequently use the vein light, which is a light to allow you to transilluminate the skin, to make sure that I'm seeing all the varicosities that I want to remove. When you're doing your laser vein ablation, as you know, you're giving your tumescent anesthesia in the saphenous compartment. When you're doing a phlebectomy, though, you're giving it all in the subcutaneous tissue. You don't give any local anesthesia in the dermis at all, but rather you create this tumescence or turgidity in the subcutaneous tissue that allows a dilute lidocaine to diffuse into the skin to provide dermal anesthesia. You have to make skin incisions on the legs, and if you look at Langer's lines of skin tension, it would tell you that transverse incisions are the best, but in fact, vertical incisions always heal better on the leg. So we make small vertical incisions, except on the anterior knee, ankle, and foot region, where they're very prominent skin lines, and you can make an incision right in the skin line and have it be completely invisible. This is just an example of a patient who had, that I saw, who had transverse incisions, and for whatever reason, they always stand out and don't disappear. This would be an old school phlebectomy. This is the way I was taught how to do it 30 years ago. You'd make a big incision about 1 inch long, take a hemostat, stick the hemostat in and just kind of rooch around until you grab something, and then pulled and something would come out, everything would bleed, you'd hold pressure for 5 minutes and think you were a hero. But these days the way we do a phlebectomy is by making a very small incision, vertical, that's maybe 1/8 of an inch at most in diameter, and I do it with a little 15-degree ophthalmologic beaver blade. I tend to make the incision slightly below the area where I mark the vein, because when a patient lays down in the supine, the vein tends to fall a little bit posterior. Then you need to have some vein hooks, and there's probably 8 or 10 different types of vein hooks available, including crochet hooks that you can get from your Hobby Lobby. The kind that I tend to like are these Osh-type hooks, which have a semi-sharp tip that will help you engage the vein, but it won't engage the skin, and makes it very easy to facilitate extraction of the vein through this small incision you make. The other thing you'll need is a few mosquitoes, but this is basically 1 vein hook, 1 blade, 2 or 3 mosquitoes is all you really need to do a phlebectomy. So it's not a significant capital investment. So the hook goes through the incision that you've made, and the only thing that should ever pass through the incision is your vein hook. And then you have a general sense of where the vein's going to be. You reach in and try to pull. If you don't find it, you generally search all 4 quadrants, but most of the time, out's going to pop a vein that you are looking for here. If you can't find the vein through that incision, go make an incision somewhere else. You're going to put a little piece of tape across it. No one's going to be able to see the incision in a week or 2. So don't go make the incision bigger to try to find a vein. Just go somewhere else. And what you're always looking for when you do a phlebectomy is, I call it this upside down U. And it's a little easier to see here. Oops. We'll get back to that in a second. The other key to doing a phlebectomy, in my opinion, is to be able to palm the instrument. And this is kind of a surgical technique where, rather than putting your fingers through the holes of the mosquito, you grip it in your palm and you open and close the mosquito using the thinner eminence of your thumb. It takes a little practice to do that, but if you're holding the mosquito with your fingertips and pulling from, 3 or 4 inches away from the skin, the vein tends to tear very easily and very quickly. But then basically what we wind up seeing is we slowly are pulling the vein out from the skin, and if you look here, what you're looking for is this little upside down U, and this part of the vein is coming up this way, and this part of the vein is coming down this way. And I already pulled the part from the top, but basically what I'm going to do is I'm going to just grab the vein with the mosquito right up here, and I never try to pull more than 1 centimeter or 2 of the vein out of the skin at one point. As soon as your mosquito gets any further than this away from the skin, the vein is just going to tear. So I'll pull to here, and then I'll re-grab at the skin level, pull a little additional piece of the vein out, re-grab, and if you do that, you can actually get surprisingly long pieces of the vein. And you can see here, I've pulled to here, and now I'm going to actually just re-grab here and pull some more. If you're doing this and the veins are just tearing and you're really unable to get out nice pieces, usually what I do is ask the patient, by the way, have you had sclerotherapy before? And usually what they'll tell you is, yes, I had extensive sclerotherapy in the past, but it didn't work. Because as I mentioned earlier, when they've had sclerotherapy, the veins become quite fibrotic and they just don't come out very well with phlebectomy. And those patients, if they need it, I will do sclerotherapy on in the future. But basically, when you're done, you can wind up getting significant pieces of the vein out here. And you see I did it through 1 small incision here and 1 small incision here. You don't have to get every little piece of the vein out. Generally, if you interrupt it in enough places, the intervening segments of vein that you may have left behind will fibrose and go away. You can deal with branch points. Here's a varicosity coming down, and here's a part that I phlebectomized from here. And you can see a separate part here, so I'm going to grab this with the mosquito and just slowly tease it out 1 centimeter at a time, and wind up getting this sort of segment here. And by the time you get all done, you can see in this particular patient, have almost all of the veins out. And if you're pretty facile with it, it doesn't take a long time. If you're first starting to do phlebectomy, what you're looking at here might take you half an hour, 45 minutes. This actually took me about 5 or 6 minutes to do the whole thing. So practice makes perfect. The more you do, the more you get comfortable with the technique, the faster you're going to get at doing it. And for me, adding a phlebectomy to a vein ablation generally adds no more than 5 to 10 minutes to the procedure. I don't tend to do a lot of phlebectomies anymore. When I first started doing this, I might make 15 or 20 incisions, but it's rare that I make more than 8 or 10 incisions. By the time you ablate the vein and remove the large proximal varicosities, everything beyond that generally will disappear without a phlebectomy. Here's another technique that you can use if you're just getting started and you're not comfortable with pulling. I call it the Barber pull technique, but basically you just grab the vein with a mosquito and you simply start twisting your hand and wrapping the vein around the mosquito like this. And it's basically going to apply tension right at the level of the skin here, and you keep twisting, and eventually the vein's going to tear, and then you're going to move down, make an incision somewhere down here, and just repeat the process. For patients with C2 disease, that is patients without stasis changes, I think the appropriate treatment for perforators is either sclerotherapy or phlebectomy done at the time of the vein ablation. And this is, in fact, a perforator just above the medium malleolus here, and it's really easy to take these out with phlebectomy. Here's an incision, here's the vein. I'm going to tease it out, and there's a little perforator segment that I have right there. All you really have to do is hold pressure on it for a minute or so. The bleeding stops. You put a compression stocking on afterwards, and you're done. You don't have to bring the patient back for a separate laser vein ablation. On the other hand, if they have C4, C5 disease with stasis changes and ulceration, you really don't want to make an incision down there, and it's probably safer to treat that perforator with either a vein ablation using heat or sclerotherapy. Every now and then, if you have a really large vein segment that you're afraid of avulsing, there's nothing wrong with taking a little ligature and putting a tie around the vein. You all know how to tie suture. It's not a complicated thing to do, so we keep a little Vicryl suture in the office, and probably 1 out of every 20 patients, for whatever reason, I've just decided that I'm going to put a tie around the vein to reduce the risk of bleeding, or to reduce bleeding and hematoma after the procedure. The ones that you think are going to be the most difficult to do, these big cluster of grapes that you see behind the thigh and calf on these patients, are frequently the easiest. So the ones that you think you want to do last, once you're experienced, are actually good places to start, because these veins come out. You make a little incision right here, and this entire, that has to be a foot long segment of vein just kept unraveling. I kept pulling a centimeter at a time and got out these multiple long pieces. So don't let the big cluster of veins scare you. The worst thing that happens is it bleeds a little bit when you avulse it. You hold pressure on it for a minute or so, and the bleeding stops, and you move on. Remember, when you've done your phlebectomy, you've eliminated the truncal reflux in the saphenous vein. You put in Tumescent Anesthesia, so you have vasoconstriction, and you see very, very little bleeding generally when you avulse these large varicosities. And when you're done, you're left with these small little incisions here. We use a little steri-strip to close those. Some people don't use anything. They just let them swell and coapt. But we use steri-strips. We put the patients in a compression stocking. We have them use a compression stocking for 5 days. No one requires anything more than Tylenol or Advil for pain. The day of the procedure, we have them elevate their leg to reduce swelling and bruising, and the next day they're allowed to return to normal activity while using their compression stocking. We have them wear compression for 5 days, and then they're done. But with phlebectomy and thermal ablation, you can see very quickly this patient, we ablated this portion of the great saphenous vein. This portion is in a subdermal location here, and I prefer to treat that with phlebectomy. I think you get a nicer result. Removed all these varicosities, probably, believe it or not, do no more than 6 or 7 incisions, and there's a patient's leg 6 weeks later. Again, just a point, one of the complications, if you see fat on the vein that you're removing, you want to try to strip that fat off, because if you remove much fat with the vein, particularly in a thin patient, the posterior wall of the dermis will become adherent to the superficial fascia of the leg, and they'll get skin dimpling. But the real reason I show this is to demonstrate the importance of taking photography. I don't know if we're going to talk about this at all, but you always have to take pre-treatment photographs of any patient that you do anything on related to the veins, whether they're spider or varicose. Because this leg used to look like this. I subsequently treated this leg. She got a great result. I saw her about 10 years later, and I asked her how her legs were doing. And she says, oh, they feel great, but they just look terrible. I don't know why I had anything done. And so I had to snap a photo, and that's how her legs look 10 years later. Her veins are all gone, but she just has spider veins that have come on. Patients never remember what their legs look like before you treat them. And if you don't have a photo to document it, you will find yourself in a difficult position. You can do veins on the foot. Again, I would wait until you're pretty experienced, because there's lots of sensory nerves down here that you can injure. You can injure a sensory nerve up here, and they're so duplicate that the patient will never know, but a sensory nerve on the foot they might. There's just a before and after. And so in conclusion, phlebectomy is a technique that can be learned and mastered with time. I think any vein 4 millimeters or larger in size, you'll get a nicer cosmetic result doing a phlebectomy as opposed to sclerotherapy, and complications should be few and far between. Thank you. No, Dr. Sanchez. Or Dr. Javier, I'm sorry. So Dr. Javier is a cardiologist from Naples who's been treating varicose veins for quite a while. He was way ahead of his time in doing this. and he's going to speak to us now a little bit on phlebectomy, what veins to treat, what veins to pull, what veins to inject.
All right, well, very happy to be here. This is my first time at CVC, and they really have a very good group of faculty. So I'm going to talk to you today. My talk is very simple because there's not much data on it, and actually Dr. Golden presented a lot of it, but I'm going to talk to you about when do you pull or when do you inject. Okay, this is my disclosure. Part owner of Vascular Device Partners will not present any products that are related to it. So just to give you a little reminder, the classification of spider veins, you have the type 1 and type 1A, which are those that are less than 1 millimeter, and then you have the type 2, which are 1 to 2 millimeter, and then you have the type 3, which are those 2 to 4 millimeter, and it's those 4 millimeter reticular veins that a lot of time you ask yourself, well, what do I do with these? Do I inject them with sclerotherapy or do I pull them? Well, you're going to see a lot of these patients in your office, and all the patients do well with sclerotherapy, but one thing that Dr. Dolan mentioned is that they get immediate cosmetic results, and the question is that when you see these patients, what do you want to do with them? Do you want to inject them or do you want to do phlebectomy? Just to remind you that sclerotherapy comes in either liquid or foam. Actually, foam sclerotherapy is off-label for polyrocanol and cetrodecol, although just recently in December of last year, Varicose, which is a foam polydocanol with high concentration of nitrogen, just was accepted, and I think it's already on the market. And but is not generally indicated, foam sclerotherapy, for those less than 2 millimeter. And we tend to use it only for reticular and for ultrasound guided sclerotherapy. And there's a problem with reimbursement many times with these for reticulars. The foam sclerotherapy indications in most of the world, they use it for actually primary treatment of great saphenous vein and small saphenous vein. We use it many times for those recurrence vein after ligation or stripping, for venous malformation, sciatic nerve varices, perforating veins, and also adjunctive for post-EVLT or thermal ablation. Now, all varicose veins can be treated with sclerotherapy, and actually I was just having a conversation with Ron Bush out there. I have a center in Santo Domingo, Dominican Republic, and we use sclerotherapy a lot because catheters are very expensive, and he was just telling me the experience that he had in Haiti using sclerotherapy. So this is only one of the few places that we can afford to use these catheters. European countries also do it, but sclerotherapy is widely used for all kinds of veins. So the larger veins require stronger sclerosing, so that leads to trapped blood, pigmentation, and a questionable increased risk of DVT, although very rare. I treat both technique, whether I'm going to do phlebectomy or if I'm going to do sclerotherapy the same way. I look whether the reflux is actual in nature, perforated vein reflux, whether they're associated with the reticular vein or they're isolated spider vein. So the basic principles that I use for both techniques is that if I start proximal and go distal, and I go treat the larger protruding veins and to the smaller. I treat the entire varicosity session, and I try to use the lowest amount of concentration of sclerosing possible, and I'm very careful with extravasation to avoid the complications Dr. Golden presented. And then after the procedures, I do use compression and early ambulation. Now, the problem with large vessels is that when you use sclerotherapy, you're going to get pigmentation because of that trapped blood. And then you have to extract that blood. And the patients don't like having to come multiple times, especially those at work. And if you don't extract that blood, that becomes pigmented, and they're not happy with it. So doing sclerotherapy on these large veins, they don't do very well. So microphlebectomy is actually a very good technique to do for these patients, although there's very little report of microphlebectomy for reticular. And actually, microphlebectomy was introduced in the early 90s, although Dr. Mueller kind of developed it in the 60s. But it's really taken off, and with the vein practice is growing these days. And basically, Dr. Golden showed you what you do is a stab incision, no sutures, with patients immediate ablation. And the most important is that you get immediate, very good cosmetic results. You use the same Tumescent anesthesia that you use for your thermal ablation. And these are some of the complications that are, although rare, you may see them. You can get some skin blisters, keloids, swelling, skin necrosis, some lymphatic edema, neurological hypoesthesia. These are the danger zones for microphlebectomy, and I would recommend that you stay away from it because of the amount of nerve and the fragile skin and the thin skin that you have in the foot. So try to avoid doing phlebectomy at the foot, or avoid doing phlebectomy in the foot, and prefer sclerotherapy at this area. Nerve injuries are very common reported with phlebectomies, and numbness actually is reported in up to 30% of multiple studies in the literature. However, most of these go away for 3 to 6 months, although some rare occasions you may have patients complaining up to 2 years with the sensation. And severe nerve injury is very rare. The higher risk is actually at the levels below the ankle. This is a device, a microphlebectomy device that the company promotes as a good microphlebectomy for reticular veins. This is by Impact, developed by Dr. Boyle and Dr. Jones. And basically what it does is it has a little needle on it, and then you press these handles, and a hook comes through it. And then with a hook, you get your reticular veins, and then the hook retracts, and you're able to pull and do microphlebectomy at these veins. These are some pre and post pictures that you have of reticular vein doing with actually very good results. You can see here before and after. And then also a larger reticular veins of type 3. You can see that they had actually very good results with this device doing microphlebectomy for reticular vein. They also shown that actually it works on larger veins, so they had very good results. However, it is an expensive device, and you have a more less expensive alternatives to do your microphlebectomy. So the question is not to pull or to inject, but rather to pull and inject. I actually consider phlebectomy and sclerotherapy adjunctive therapy. There's not much data out there using the combination therapy or comparing one with the other for reticular veins. And you're going to see in your practice that many patients present with a variety of conditions. So it's very good that you get the skills of treating both conditions and develop the skills for phlebectomy. And it's actually a very easy procedure to do. You do not want to refer your patients to another center. So basically, what we ended up doing with this patient was that I actually did microphlebectomy and did sclerotherapy. And the way I tend to do it is I actually do the sclerotherapy before I do the microphlebectomy. And the reason why I do it is because the veins get contracted and they're a lot easier to pull. But I do it on the same day, because if you do treat them before and you bring them later to do the microphlebectomy, you're going to have a lot of scar there, and it makes it a lot more difficult for the microphlebectomy to do. I had a video to play, but it seems like it's not pull. So basically avoid the ankles. And can you play the video? It's slide 16 or 17. For some reason it didn't. Before go back. It was no, it was right before the microphlebectomy. It seems like it didn't come through. No? Okay, so it didn't go through. So basically, let's go to the. In summary, you need to know what are your patient's expectations, if he's there for symptoms or if the patient is there for cosmetic reasons. So you need to ask them what they want, and depending on what they want, then you offer the treatment. You need to remember that these treatments, or even though you're doing phlebectomy, when you're doing phlebectomy for large bulging veins along with a thermal ablation, you can't get reimbursed for that by the insurance. But if you're doing it for SEEP1, you do not get reimbursed for that. So talk to the patient and see whether they're getting it for symptoms or aesthetic. Many of your patients will actually need both approach, and it's very important that you actually have these both treatments available. You do not want to refer your patients to another vein center to get the other treatments that they would need for the legs. Thank you very much. This is a hands-on course that we do have for multiple physicians that want to learn phlebectomy or ultrasound guidance sclerotherapy, and that it's available to you. Thank you very much.
Thank you very much, Dr. Javier. And I can't emphasize enough on a summary slide that you really have to understand what your patient expectations are so that you can really try to meet them. Dr. Romy Chopra is an old friend of mine. He was an early adopter of vein ablation in Chicago along with me, and I think has been doing this probably since 2003, 2004. Okay. And he's actually going to have the next couple talks. He's going to talk a little bit more about phlebectomy. He has a video that actually shows how to do a phlebectomy real time. So, Romy?
Awesome. Thank you so much. How many of you here done any phlebectomies? A handful. Okay, so I'm going to try and make this less of a lecture and more of a hands-on how you do it. So if you have questions, interrupt me. I think I have all the last 3 sessions of mine, so we got 40 minutes. We'll make this practical. Are you playing the video first? Music sounds good. Just gladiator time. You can imagine me run up the stairs. Yeah. I like the progressive part. So we'll watch this once and then go through it.
I'm going to demonstrate to you the procedure of phlebectomy. We have a young lady here. She's 32 years old, has had venous reflux. She's had other treatments done before. She has a large branch on the lateral surface of her leg that has been bothering her. She had it injected before, but these always don't work. And what she probably needs right now, obviously, is phlebectomy. I'm going to demonstrate to you. I'm going to focus on her leg here and show you. What I have in my hand is the AccuVein light. You can see how well that branch is seen laterally going all the way down in her foot. I'm going to actually mark this now with a marker so that when I'm doing the phlebectomy, it'll be much easier for me to identify the branches. So there are 2 ways. Some folks will mark it on the vein itself. Others will put it along the side. I like to get an idea of along the pathway how I have it, as you can see with that. I always hand the patient a mirror so they can see what I am going to do. Can you see that with the mirror? And so they have an idea, and I always also look for where the reflux originates from. We've already treated that, and now today she's in here for a phlebectomy. So I am now prepping the leg, and I'm just using ChloroPrep. You'll notice that these markers tend to wash away. That's where this light is actually excellent in that I can still see what I'm doing. It doesn't need a lot of fancy prepping. I usually limit it to something like this. As you can see here now, I can see the vein. I've already marked it. I know this is the segment that I want to phlebectomize. There are 2 ways you can do this. One is I give some lidocaine around this. Some folks like to puncture on top of it, or some like to go in slightly from the side. Personally, I like to go a little from the side. Feel a tiny little pinch here. All right. So as you can see here, I've got Tumescent in a 30 cc syringe. I got an 18 gauge needle. I've already given some lidocaine here, so she shouldn't feel this. I like to give a little Tumescent along this track. With the lidocaine, she shouldn't feel this at this point. I make sure I'm not inside the vein, and as I'm giving some of that Tumescent underneath. You don't want to overdo it, because sometimes you lose sight of the vein as you're doing this as well. Often it'll track along the vein, as you can see here. In obese patients, it can be a slightly bigger problem. I try to take the same path and then just inject along that pathway, as you can see here. Now the beauty with this light is I can still continue to see the vein underneath. If I switch off this light, you will see how difficult that becomes. Now you can see without the AccuVein light, all I can rely on is these dots. And with those dots now, I don't exactly know where the vein is underneath. So now for phlebectomy, I prefer to use those, the AccuVein, and I can see what's happening underneath it. So I'm going to turn the light back on and try and go from there. So I try to make as few puncture spots as I've just done one. I'll go back the other way as well. And I aspirate just to make sure I'm not inside the blood vessel there. And then also give a little further higher up. So one way to do this is you can just use the bare scalpel, or, which is the number 11, or put a little hemostat on it to prevent it from going too deep. I'd never find the need to really do that. There are other devices available, so I'll go right next to it and give a tiny little pinch. You should not feel any of this. Down the leg, I've learned you want to make this as vertical as possible. As you can see now, I've got the Mueller hooks here. There are 4 different types. I'm not too picky. I tend to do way less phlebectomies than I used to, and you try to match the one that'll fit the size of the vein. So I'm going to try and use this one right here. And I've got that tiny little skin nick. I'm going to go in there, get underneath that branch, hook it up, you feel it, twist it around, and you see the pearly white vein coming up. If you give adequate tumescent, you rarely ever hear complaints from the patient. As you can see here, I've got the pearly white one, and you tend to land up tugging on it like that. Oftentimes they break like that, which is okay, and then I'll grab one end on one side and pull it. And oftentimes I may not even pull the whole thing out and actually just let it break underneath and just go back and forth. Got a little oozing from there. So here now, that was the first side. Sometimes you won't get it. You'll feel a little tag of the skin. You can see that, but I've broken the vein. That's good enough. I'm going to try and catch it up here, higher up. And you can see now I got that, and you see the whole segment popped up at this end, right there. And I can grab that, and as you can see here, pull it out. Sometimes they're fragile because these are damaged veins, and they pop right out in your hand. As you can see right there. You'll see a little oozing from here. That's the 2 spots. I'll do one more up here. The 3rd spot, just again a little higher up, same, grab the vein underneath, pearly white. Oftentimes you could potentially catch a nerve fiber next to it, but if you're careful enough, you won't, and if there's not a lot of inflammation, you'll see. But you know you're in the vein if you get heme like blood like that, and looks good so far. And some people get excited about how much they can remove, but if you want to pull this out now, you take this, not more than a centimeter or a few millimeters at a time. Literally, you catch it underneath, you pull on it till it actually literally tugs and breaks at the other end. And I've reached that point, and I can see her jumping a little bit because it probably pulled up at a spot where this was not anesthetized. And then a little compression. Often you'll have a little skin tag right at the spot. But you can see otherwise it's good. If you get the skin tag, I'll usually just, not a skin, but just a tag from some fibers. I put it in because you don't want the tag staying out to heal. I then will clean this up with some hydrogen peroxide. It tends to work pretty well. And then after that, put in Steri-Strips on it. So as you can see here, after a while the oozing stops. If you turn on the AccuVein light, you'll see that's fragment. There'll be some heme underneath that. It will look like a little bruise along that track, as you can see along that pathway. But we know we've broken up that fragment of vein. The one underneath will not fill much anymore, and we've already taken care of the perforator higher up. Right. I'm going to clean this up with a little peroxide, just some thrown on a gauze. It helps clean the wound up, but also not really a wound, and at the same token, it also acts helps in rather stopping the blood from oozing out too much. So I'm going to now put some Steri-Strip on it, and what I'll do is tend to go up and across it. As you can see, it's pretty clean. I'll do one the other way. There's no real formula to this, but just enough to keep the tension on it and let it heal. I ask the patients not to take this off for 24, 48 hours, or I literally just let it kind of fall off on their own. First 24 hours, I'll often tell them to put something like a saran wrap or something on this and just let then they can have a shower. I don't limit activity. I think activity is good for them. As you can see, it looks very good. We give her a nice compression wrap at this point. One of the secrets to compression is you don't want to compress the entire leg. What you want is the compression needs to be on the vessel or the vein that you just treated. So I tend to roll up a gauze like this and put it along the pathway of the vein. And then I will give them a wrap. So the rest of the muscles have just normal compression, but this is the one that is really getting proper compression. All right, thank you. That's phlebectomy. It's fairly simple to do. This was a much easier case. Oftentimes you can have large branches going across the thigh or almost down the entire leg. So as you can see here, that rolled piece of gauze is right underneath. That was along the path of the vein. Then we have some gauze right here. This allows, if there's any oozing from the tumescent or blood, to be absorbed, and then a compression on top. And it's not very tight. It's enough to give her a gentle compression, but the inner gauze allows the compression to be on the vein itself. So this was a simple phlebectomy procedure. Sometimes they're much larger. Could be in a larger patient, a larger branch in the thigh. It's important to know that the source of feeding has been taken care of. Otherwise, when they stand up, they can bleed a lot. But as you can see, it's a very simple and easy procedure.
All right. Start with some questions, and then we'll kind of tackle this. We got 30 more minutes. So, any questions so far? Yes, please.
Sometimes it seems like right below the knee, around the knee, the veins look large enough that they would be pretty easy, and you can snare them, and then they seem stuck. Is that some kind of inflammation that we don't understand? Sometimes they'll come out very easily, and it's very gratifying, and otherwise they seem stuck and they won't come at all.
Yeah, I think the important thing is to step back to the very beginning and say, what are we treating? So we're treating, in the first place, all the manifestations of venous hypertension, which come from venous insufficiency. And if it's truncal, especially junctional, then we want to treat that with venous ablation first. Then we get to, okay, now I need to take care of the branches. Is it filling from anywhere else, like a perforator from below? If it's not, then I need to now get rid of this branch. Can I do it with foam, sclero, which I do a lot of compared to phlebectomy? When they don't come out easily, to me it means there's been either phlebitis, which happened on its own, or there was sclerotherapy that caused the phlebitis. So there's inflammation, and now that vein's hard to pull out. The second thing that really happens oftentimes after this is if they've been very distended, then they're very fragile and they break easily. And you're not really getting the results that you want. So I think it's important to put phlebectomy in the framework of taking care of the patient amongst all the techniques versus an isolated technique. These are the first two speakers, Dr. Javier and John, alluded to as well. And I think that's the important part of this. I used to do at least 3 phlebectomies a day. I mean, I do as many as 100 ablations a month. And each one of them would get phlebectomies. Now I do 3 ablations a week. And that also is sometimes a little too much. So I'm doing very few phlebectomies. There's a financial aspect to this as well. How many of you who do phlebectomy know that there's a 90-day global period for a phlebectomy? So if you do an ablation, which you often have multiple sites in the same leg, such as you'll have a greater saphenous vein ablation, there may be a lesser saphenous or a large perforator. I see ones with massive wounds and ulcers, and there are many perforators. If you do a phlebectomy, and depends on which insurance it is, but especially Medicare, let's say you did an ablation first and a phlebectomy, And there's a 90-day global period. If you land up doing an ablation in the middle, you're not getting paid for that. And that's something it becomes important to look at as well. But most patients tend to hate phlebectomies. If they had a choice not to have it, they'd rather not have it. So it's the idea of pulling something out. So I spend a lot of time explaining everything to the patient. So my first visit itself, I sit down with them, I show them pictures, I literally give them a mini presentation, if you would. At that time, they always stop at this phlebectomy slide and they go, but you just told me that you don't pull out veins anymore. Because I tell them we don't do stripping. Then I have to backtrack and say it's a mini phlebectomy or this or that. So there is a psychological component to that as well. Any other questions? Did I answer your question about the inflammation and phlebitis? If not, what I can do is play my next, run through my next set of slides and touch upon all these points, and then maybe come back to the video if anybody had some specific questions. Any comments, John, on the technique?
I think we'll go through your next talk, and then we'll have some questions and answers.
Okay, sounds good. So now, how do you really get the best outcomes? It's all about outcomes. It's all about getting what you really want to accomplish with patients. So you ask the question, why did the patient come to me in the first place? And what was really going on? So when we look at, is there something missing on that slide? All right, the title, all right, let's go back here. So what is phlebectomy, just to catch up with that definition for once? It's the removal of incompetent veins below the saphenofemoral and the saphenopoppliteal junction. So it's important to understand that you will not be doing a phlebectomy of the greater saphenous or the lesser saphenous or truncal veins. And here's an important point. Even a patient of mine, this very early on, I did a greater saphenous ablation, but he had a large anterolateral branch. He said, I'll do a phlebectomy. So we did the phlebectomy. He's laying down, we did all that. He stood up, and we had wrapped it, and we stepped out the door. Just as he's walking in, we hear him scream. So I run in, my nurse runs in, and he is standing in a pool of blood. And it's just pouring down, so obviously we put some pressure, have him lay down, and then I used the ultrasound. What I found was that this branch was coming off the top, maybe 2 centimeters of the saphenous. And it was really, I should not have done that phlebectomy unless I knew that the source was completely treated as to where is it filling from. So that, from that day on, I knew that before I do a phlebectomy, I need to make sure that the source of the hypertension, which is from where the incompetent valve is, has been treated. So that becomes extremely important. The other things are some veins may be deep versus superficial. Phlebectomy is good for the ones that are more superficial. Now, we have some very obese patients in the US as well. So sometimes you'll see very obese patients and you know they have a large branch, and then you try to dig in and do a phlebectomy. You can land up with some issues. You're pulling and tugging, you pull on nerves, you can hurt a lot of different things. So junctional reflux definitely must first be addressed by ablation. Also, reflux from a perforator. So my philosophy on this, which is traditionally what has been taught, is you examine from bottom to top. You start by looking at the feet and work your way up, but you treat from top to bottom because you're fighting gravity. And then you work your way down, okay, the greater saphenous, saphenofemoral junction, is there some perforator in the mid-thigh that's feeding that system? And then work my way back and then look at what other manifestations of the venous hypertension. If it's a venous ulcer, where can I trace that pressure back to? If it's just venous skin changes, where can I trace it back to? Or even for cosmetic for that matter, if you're looking at some reticular veins. So as I work my way back, I know I'm looking at the source. Once I've treated the source, then I go to quote-unquote the adjunctive therapies, which may be foam sclero, regular sclero, or venous ablation. So in any of these patients, there are, in my opinion, 3 outcomes you're looking for. If there's a venous ulcer, you want to heal it. You want to treat the venous hypertension, and therefore you got to deal with the venous insufficiency. So the first is if the patient has an ulcer, I want the ulcer to heal. Second is if they have pain and swelling, I want that to be relieved. and third is cosmetic improvement. And with those outcomes in mind, you want to work and see what works. So what I land up doing, and in our practice we do now, is when the patient comes in, we first ask, obviously, do the history and examination, find out what is really the problem. Once we have that, we establish a goal of treatment. So we say, okay, you want your venous ulcer to be healed and you want pain and swelling to go away. Cosmetic is not my problem. If it looks ugly, it's okay. As John said, take a lot of pictures. So we take pictures at every visit. In addition, I actually take pictures during the procedure of where my puncture site is, where my needle site is, and I put it as part of my report as well. All right, so once we've established what our goal of treatment is, then with that in mind, as in this patient here you'll see, we treated his truncal reflux. We know he has no more reflux, but this is still filling. He had a small perforator at the other end, not enough to warrant laser ablation of that perforator. So then he had a phlebectomy, and you can see he did well. No inflammation prior, so these come out very easy, and as John described, Dr. Javier described. Now, patient selection becomes very careful. You can also do this for lateral reticular as they get bigger, set above 4 millimeters. So if you look at the first one I showed you was right off a truncal branch. You can do this closer to the groin, to dental veins, and then you can do the lateral. These days, I tend to do more of foam sclera for all of these. I find a nice spot, put the foam in, and with the ultrasound, actually massage it up and down, and then give it enough time. The concept with foam sclera or sclera in general is you are actually ablating the vein. You are hurting the wall of the vein, but it's a chemical ablation, and you want maximum contact time of the chemical just sitting there and damaging the endothelium. And I tend to do less and less phlebectomies on the outside. In addition, for venulactasia, especially if you have a bunch of them, like venulactatic matting, you can actually put the probe in and scrape out those branches. I used to do that, don't do that at all anymore. Now what I'd rather do is map that down to find out which branch, perforator, or reticular vein is feeding that. Get into that branch, but do foam sclera and watch it come back into all the smaller branches. And I find that my cosmetic work has become even better by taking care of those first instead of just. So the analogy I give the patient is, think of your skin as the pond, water. The reticular veins on the top are like leaves. If they're leaves, there must be branches. If they're branches, there must be roots. If you only trim the leaves, leave the branches and the roots alone, leaves come back. So I always work my way to finding out, even when they come for cosmetic work, I will work my way to seeing where the reflux is coming from. If I see a reasonable sized perforator, I will work my way to see if they have any symptomatology. If they don't, it's part of the cosmetic self-pay package. I will do a foam sclero and kind of take care of all of those, and the cosmetic results are dramatically better. So now if you look at this patient here, she had 33-year-old woman. I'll never forget her because she was the grumpiest woman I ever met. And this explained why. She was a very attractive young lady, but had not worn a skirt since she was a young girl. And this bothered her. She couldn't play sports. It was a problem. It had bled once before. And we had taken care of the saphenous vein reflux, and then after that did a phlebectomy, and you can see she actually did pretty well. This was just a few weeks later, and this is one of my very early patients. These large ones, definitely easier to do and come out, but at the same token, if you've not taken care of a source of reflux, and I point out in this patient because there could be a perforator coming out from the mid-thigh feeding this. And if you've only done the saphenous and you think it's okay, and then you start pulling these out, they stand up and they can bleed. And they get bruising, hematoma, and I've even seen a very bad infection, which we'll get to, which is very rare, but which is a no-no spot, so we'll get to that in a second. So again, I mean, the areas you want to watch for, which can be in terms of pain, when you get close to the groin, if you're looking at your dental branches. So again, you want to make sure that there's no underlying deep pathology before you start attacking those veins. The second thing is in the popliteal fold or over the knee. These can be very painful spots, and over the foot, as you've heard earlier as well, and go from there. So what are the undesired outcomes? What is it you don't want? We definitely don't want them to be screaming in pain during the procedure, number one. Second is bruising, extensive bruising. If they have a lot of treatment and the very first on session you do some phlebectomy and they get some extensive bruising or bleeding, they get demotivated. As that one patient I described to you, I did a anterolateral branch and he just poured blood out. Now imagine if that had happened at home. Hematoma, some situation like that. Paresthesias and nerve damage, which is actually very, very common. I follow these patients longitudinally for a very long time. I have patients who are out with me 8-9 years. They will come back. I even do free visits just to make sure nothing new is popping up, and also for cosmetic stuff. And that is the one thing that they constantly complain of, numbness, especially below the knee. So I've been very careful of doing phlebectomy now more below the knee in the lesser saphenous and the greater saphenous below the knee. Infection is rare, but if you are dealing with patients with ulcers especially, and you land up working, you see a large branch either under ultrasound or feeding the area of the lipodermatosclerosis in the ulcer, and you try to phlebectomize that and you make a nick in there, there's a lot of bacteria in that region. And one patient, I saw from a wound care center where somebody had tried to do a phlebectomy first. And that patient landed up in the hospital with a massive infected wound that went down to his bone. And this took him 9 months to heal. That area, in general, you don't want to do it around the ankle or the dorsum of the foot, but definitely in areas where there's wound, I would highly recommend you stay away from them. Some tips and tricks, small incisions. I even use an 18-gauge needle sometimes, just make a little hole enough for the hook to go in and grab it, especially in the moderate size ones. In the very large ones, you still need that 1 to 2 millimeter nick or 3 millimeter nick to get in there. Hooks, choose the appropriate one. Avoid the long pulls that you heard the other speakers say. And one important thing to realize is to also try to avoid stretching that incision. And that's another thing that bothers patients, especially if they are cosmetically aligned, if those tags stay for a while. And definitely avoid the areas around the venous ulcers, because it's not uncommon to see a large branch feeding that area if you check under ultrasound. Or you may even see something out there, and with wounds especially, I see patients with 10, 15 massive perforators that are feeding, and you want to avoid those areas. Phlebectomy hooks, really take your pick. As John said, you can go get a crochet hook if you like. So that's something, once you get used to it and know what you're doing, then that'll help you improve your technique. So again, many different types. Pick the one that you like. Marking of the skin, as I explained to you earlier. I got the AccuVein rather recently, and that is spectacular in terms of what it shows. It's not good for very deep veins, but it's very nice to show the patient, very good for superficial stuff. It doesn't show you much reticular veins, and it has really changed for me how I can kind of mark those patients. This is something I'd like to stress as much as possible, is find the underlying source. If it's a perforator, I do a lot of perforator ablations now, and I found that for the very large ones, it has really dramatically improved my outcomes as well. So that's another important spot. Marking, as we talked about, good light source. Play with whichever one you like, vein light, the AccuVein, ultrasound sometimes to see what exactly is happening there. Tumescent anesthesia. As you saw, I don't use too much tumescent anesthesia, and that patient was rather skinny, but you could have fairly obese patient or chunky, and you can lose the vein completely. You just keep digging around, you don't know what exactly is happening. So I tend to give just along the pathway, but if you're sometimes pulling, the vein may pull at a spot where there isn't enough anesthesia, and that really hurts, to be careful of that spot as well. Small skin incisions, but very important to avoid. If you start seeing, other than the pearly vein that comes out, a tiny fiber next to it, you know you're touching a vein. A patient often will complain if it's pulling on a big enough nerve. You want to let it go back in, go from another side and try to pull just the vein out. If it comes out, don't cut it or just put it right back in. If there's any fat, try to avoid getting the dimpling in there. Bottom line, keep it simple. Explain calmly and simply to the patient. I believe that less is more. Initially, we used to be very excited about pulling out long segments. We would take pictures, and I think you just interrupt them enough. And interestingly, it's also compensated by number of incisions that you make. And I have a feeling that will get changed at some point. It's like up to 10 or 20 incisions, a certain CPT code, and then beyond. Always treat the underlying source of the reflux first. I combine a lot with foam sclerotherapy now, and then what I do is, and sometimes I don't even bill for it as a phlebectomy because you need 10 incisions minimum, and I'm making 2. I just take the top 2 spots where the reflux may be coming from, and I just interrupt the vein and let the foam part of it work inside, and get fantastic results with that. I'm really just breaking the connection to the underlying reflux, and obviously avoid any nerve and skin damage. So great, we'll take more questions and go back and forth rather than just continue speaking in the monologue. So, questions, comments? Yes. Actually, as part of so the question was, how do you see perforated reflux? So at the very first time when you examine the patient, you got to say, what is the problem? Where is the venous hypertension coming from? And where is the venous insufficiency that's causing the venous hypertension? It has to come from deep to superficial. So you see a patient who's got venous ulcers, and let's assume for a moment the greater saphenous is no reflux. Lesser saphenous, no reflux. So where's the venous hypertension coming from? It has to come from some perforators. And the entire segment of the saphenous does not have to reflux. Maybe just one portion is refluxing and the pressure is coming through. Ultrasound is the main key. And then a good ultrasound tech will pick it up and identify the perforators. So we identify all the perforators that are leaking, how much reflux is there in each one of them. We have a matrix. And then I try to match the clinical problem with what is seen on the ultrasound, and we submit that all to the insurance. So the answer is ultrasound, clinical examination and ultrasound. Did that answer your question? Any other questions so far? Thoughts, ideas, comments? John, any comments?
No, very good. Are there other questions? We have a few more minutes regarding anything that's been discussed this afternoon.
Yes.
I might have missed this with Dr. Golan's talk because I came in a little late. When you get a phlebectomy that develops a hematoma a week later, they come in with this kind of big bulgy area that's clearly lysed blood. How do you treat it?
Well, the first thing is to avoid that. And the way you avoid that is that blood came from somewhere. That means it came from a perforator or another large source of reflux that was not treated. That's where the pressure is coming from. So that's number one. So I make sure that if I'm doing a large branch, that it's not filling from a perforator above or below. The second thing is at the time of the procedure, enough tumescent up and along the vein so that there's enough constriction, and then the secret is compression. So I tend to do where I roll this gauze along the path of the vein. I don't give a very tight compression for the leg because that can cause swelling and it just doesn't work for patients. So that compression after 24 hours will decrease that incident. But once it's happened, then you just got to wait till it clears up. But I will look for, is there another side of bleeding coming from there? Is it still being fed by some high pressure point? John, any comments on that?
Yeah, I would agree. Sometimes it's so bad, though, that you have to actually open up your little phlebectomy incision a little bit and try to massage some of the blood out. But it's very, very uncommon. And to answer your question from earlier, the varicosities on the anterior knee, I think you asked about, I mean, they typically are stuck to the underlying fascia on top of the patella, and they can be very difficult to get out, even in the absence of previous inflammation in them. That just seems to be an area that's a little bit more difficult. So if you're getting started in phlebectomy, Romy doesn't do veins on the foot. I do them all the time. You just have to be careful. Veins on the foot, a little bit more difficult. Veins on top of the knee, very, very difficult to get out. You need to have a little bit of experience before you'll be comfortable doing it.
On the foot, the important point is, I get patients who've been kind of all over the place. So I have one lady who comes in where she's had a greater saphenous, lesser saphenous, all that done. But a foot, she comes in my office, puts her foot down, she's just weeping liquid off her leg. And what was happening was she had 3 or 4 large perforators around the ankle and at the foot medial aspect. And some of these normally are bidirectional flow. And she's miserable. The podiatrist who sent her to me, she had a wound earlier that's all gone, but now this is just weeping. So under ultrasound, laser, and ORF, which I don't remember exactly, shut down those perfs. Very carefully, you gotta be very careful, you can burn an artery easily next to it. And then foam sclero of the feeding, of the area that's fed. I tried phlebectomy on the foot very early on, and it's quite uncomfortable for the patient, more uncomfortable for me. I just wasn't sure. But I've also done hands, a lot of hands. Patients come in and go, I hate the way these look. So I've done them where I've actually foam scleroed those, and good result, but if 1 or 2 I've had where it was large enough that I actually phlebectomized them. And it's a little challenging, but absolutely doable. I just wouldn't recommend you start day 1 with those. Bad complication will stop your career fast on that path.
Other questions?
All right, great. Thank you.
I believe there is a cocktail hour next door at the exhibitors, and I think it would be worthwhile if everyone stopped by and paid some time with the people that are helping sponsor the meeting.
The password to enter there is golden, just so you know.